housekeeping kind of items.
Great. Thank you so much, Becky. And good afternoon, everyone. This is Shelby Hornback with the Indiana Hospital Association. I want to thank you all for joining us this afternoon for our webinar in preparation for next week's Swing Bed educational event. I do want to remind everyone, as you are logging on, please go ahead and place those phone lines on mute, whether that's computer or audio. That way we cut down on that background noise. I do also want to let you know, I think Becky reminded everyone that this webinar is being recorded, so information will be sent out to everybody after the webinar if you have anyone who was unable to attend it. Bless you, whoever that was. And so then the last thing we want to do before I turn it over to Becky and Carrie is I want to go ahead and take hospital roll call. So we are just going to do that per hospital. So when you hear your hospital's name, if you just want to let me know that someone is represented from your hospital on the line, that would be great. So we'll go ahead and get started with that. Do we have anyone from Adams Memorial Hospital on the phone? Adams Memorial Hospital? Anyone from Bluffton Regional Medical?
Yes.
Awesome. And Amber, thank you so much. I have you down from Adams. Anyone from Cameron Memorial? Cameron Memorial? Community Hospital of Bremen? Yeah. Oh, thank you, Andrea. I received your message in the chat box. Anyone from Decatur County Memorial? Decatur County Memorial? Okay. Franciscan Health Rensselaer? Do we have anyone on the phone from Franciscan? Okay. Gibson General Hospital?
Yes.
Thank you very much. Greene County General? Okay, Jill, I got your message. Thank you. Harrison County Hospital? Harrison County? IU Health Bedford? IU Health Blackford? Is IU Health Blackford on the phone? Awesome, thank you so much. IU Health Frankfurt?
Yes.
Wonderful, thank you so much. IU Health J? IU Health Paoli?
Yes.
Thank you. IU Health Tipton? We have Tipton on the phone. IU Health White? And Margaret Mary, I received your message in the chat box. Oh, IU Health White, thank you. And Margaret Mary I have. Do we have Parkview Wabash?
Yes.
Parkview, okay, thank you. Parkview LaGrange? Last guy, I received your message as well as Putnam, thank you. Do we have anyone from Rush Memorial Hospital on the phone?
Yeah.
Thank you so much. Scott Memorial Health? Scott Memorial? Do we have St. Vincent Clay? Oh, yes. Vanessa, I have from Jennings. Do we have St. Vincent Clay on the phone? St. Vincent Dunn? And Vanessa, I got your message. Do we have St. Vincent Mercy? Oh, Tammy, thank you. I received your message. St. Vincent Salem, are you on the phone? Okay. St. Vincent Warwick?
Yes.
Thank you. St. Vincent Williamsport?
Yes.
Thank you. And Union Hospital Clinton? Okay, so for those of you who just joined us, we did do hospital roll call. If you were unable to let us know that you're on the line, go ahead and use that chat box to let us know. And that chat box is open throughout the presentation as well. If you have any questions for Carrie, Becky, or myself, please use that chat box or unmute your line to answer your questions at the end. So with that, Becky, I'll go ahead and turn it over to you.
Okay, thank you. Everyone on the line today has registered for the program on November the 13th. Our swing bed program that we know is going to be beneficial to you. It'll be at the Hospital Association. It'll be from 9 to 4 o'clock. We're very honored and very pleased to be working with the consultant that has worked very diligently with the State Office of Rural Health on the swing bed initiatives and program. We have Carrie Dunning. And most of you, I believe, are probably familiar with Carrie, but those that are not, I just want to give a brief introduction. Carrie has 25 years in healthcare consulting and over 30 years in the industry. She specializes in post-acute market working with hospitals based in skilled nursing and swing bed programs, lots of experience with critical access hospitals and working with them directly, freestanding skilled facilities, inpatient and outpatient, and rehab programs. She's worked with a lot of major organizations such as CMS, Yale New Haven, and the World Health Organization. So lots of good experience both here in the United States and internationally as well. She's currently working with the Indiana State Department of Health, State Office of Rural Health, to kind of help develop some quality measures for critical access hospital swing beds. And it's hard to catch Carrie because she's everywhere, assisting swing bed programs and skilled nursing facilities and meeting compliance and just really having good, strong programs. And that's one of the main purposes of our meeting on November the 13th is really to help you build that strong foundation for your swing bed program. In the email that I distributed this morning, today's presentation, as well as a document that contains some manual content information, I provided the agenda for the swing bed program for you to refer to, and you may want to open up. We are going to review some things because the day is going to be a working day for you as well as listening to the wealth and wisdom that Carrie has to share. So in that email, I also included a list of items that you need to bring to the conference, and we'll be reviewing those today during the webinar. I do want to thank the State Office of Rural Health for providing the funding for the program, and also to Shelby Hornback there at the Hospital Association and Karen Kennedy and helping pull the program together, and I think we have a great day planned. The information will be relevant to both critical access hospitals and PPS hospitals. Many of the critical access hospitals attended a program last summer in July that Carrie presented. We're going to be building on that information that was shared and also information that Carrie has shared in some follow-up webinars. It's not necessary that you needed to attend those programs to benefit from the meeting on November 13th. You'll very well receive solid information that you need to really help you and guide you in your compliance and your quality improvement efforts in your program. So new information will be shared and building on what has already been shared. We really just want to make sure that you have what you need and the information that you need to make sure that you're both compliant and you're also offering your swing bed program to a wide variety of patients. During the day, we're going to be discussing some lessons that have already been learned from the implementation of the patient-driven payment model, or PDPM, and that was just implemented back in October, but definitely something that impacts the PPS hospitals and a program that the critical access hospitals need to be very aware of. We're going to share and review updated information around conducting a self-audit of your program. And Stephanie Laws from Union Hospital Clinton is going to share their experience in their self-audit process, lessons they learned, tools that were helpful, and just some very insightful things and items that they experienced during that self-audit process. Carrie is also going to go through and is going to review what you need to look for in a swing bed claim, and will also be doing some review of some case studies that will be, I think, very helpful to you as you think about your swing bed program and the processes you have in place. The presentation for the meeting on the 13th will be sent prior to the webinar, or prior to the conference itself. So please make sure and look for that. So as you prepare in coming for the conference, we will want you to bring your hospital's swing bed admission criteria so that we can discuss and review, and you can look at your criteria as we talk about key content, and that you can assure that your admission criteria is the best that it can be for your facility and how you intend to run your program. We would like for you to also bring at least one of your hospital's swing bed policy and procedure that you consider to be kind of a best practice for your facility, or the policy or procedure that you review most often and find useful most often. We would also like for you to be able to have access to one of your hospital's common swing bed claims, so that as Carrie reviews it, you can learn to look at that claim and know what you need to look for. If you do bring a hard copy version of a claim, you must make sure that it's de-identified. We want to make sure that no PHI is disclosed, but believe that it would be very helpful. If you don't have any of the items that are listed, we will have some examples there for you to use. It's not critical. If there's something that you don't have access to, you can still learn, but you will definitely benefit from bringing these items to the meeting. So with that, Carrie, I think we are ready for you, and if there's anything you would like to add to the information that I've shared, why please do.
Thank you, Becky. I look forward to seeing all of you next week. I've set up today's webinar to go over some basics of things that we will be discussing, but I'd like to start, as I usually do, with things that are going on right now, so that you have a couple of updates, real short views of it. First of all, I've got a wrong date right there, it should be 2019. You've heard a lot about trauma-informed care, which is starting November 29th, in other words, in a couple weeks, in the long-term care facilities in the country. It was implemented in swing beds last October, so I want to make sure that you're aware of the changes that were made last October and are paying attention to them. Remember that you can be surveyed in a swing bed program by state surveyors now, and I think one of the things they will be looking for is that highlighted culturally competent and trauma-informed plan of care. There are other items there that were changed. You may want to go out and look at the conditions of participation from October 12, 2018, the changes that were done specifically for critical access. If you are PPS swing bed program, your changes really came on October 1 with the PDPM system, and that's probably where and only thing you need to be concentrating on at this point, because, as you know, we've had some bumps in the road with it. The other thing that I like to remind people is there are really two places that we see a lot of the information that we need. If you are critical access, it would be in Appendix W, which is the survey protocol for critical access swing beds. It's actually for critical access hospitals and the swing beds and gauze. If you are PPS, we used to have an Appendix T, and last year they melded that into Appendix A, which is the acute version for survey protocol and regulations. So if you are a PPS swing bed, you would look at Appendix A, and inside of that, I think it's the last or the next to the last section will be on swing beds. The other item you need to be aware of is Appendix PP. All of these are found in the State Operations Manual, and this is the guidance for surveyors. This is where you find the language of questions they're supposed to be asking you, according to CMS, because they are state surveyors, and you need to use this sort of as a basis for review of your own programs. One of the reasons I brought it up is there are a couple of hot topics right now, like a patient's choice for an attending physician, which is different in swing beds where we may have hospitalists or we may have physicians that practice in your acute that are covering your swing bed, so you need to read through that. Remember, we call everything resident rights because you are under the long-term care regulations as well as those for critical access or for those for swing beds. And you need to be looking at the transfer and discharge information, which does involve the ombudsman right now. And this is something I want to make sure that you have read. So again, you can go out to Appendix W or Appendix A, depending on whether you are critical access or PPS, and read this in its entirety. But when somebody is transferred, for instance, from your program to GeroPsych or another program like that, there must be a copy of that notice sent to the Ombudsman's office in your state. I would suggest you get with your area ombudsman and ask them what format they want. Some people just want an Excel spreadsheet. Some want to be notified of some of the transfers we have to make before the transfer is completed. Each one, under the CMS rules, has a right to translate that the way they want. So if you're not doing this now, this is something that started a year ago, and we need to make sure you're doing, because there are reviewers out looking at it. And then I want to talk a little bit and echo what Becky just said about things we're going to be working on next week. So I have it kind of written out here in this document so you can go back and look at it more closely if you have questions. But we're going to look at a couple of things, beginning with your admissions criteria, and then also some of your policies and procedures. And in that document that is labeled manual content that came today with this presentation in your email, you will see a list of short list of policies and that are often not developed in full in hospital policies because we are a post-acute setting. And that list may give you some ideas of things that you have or things that you're missing, and that would lead to a discussion that we can go through next week as to why they're there. I will tell you that State Survey wants you to be able to draw a line when they're visiting from a policy, for instance, admissions policy, to the type of patient because of the admissions policy that you've admitted and that care that has been delivered, and then to your documentation specific to that type of patient and care delivered, and then to discharge and where were they discharged. So they will often start with a policy and follow it all the way through the system. So that's why the policy needs to be updated right now. And as we've already discussed, PDPM is changing skilled nursing into more of a medically complex process rather than highly dependent on therapy. That does not mean you have to change your criteria. If you're a program, for instance, that has a lot of surgery or orthopedic where we can do a lot of therapy, then that's your program. But you need to be aware that your policy covers the type of patients that you're accepting. So we want to be able to go through, as Becky said, if you can bring first of all, bring your admissions policy, that would be great. The second thing we want to do, we want a best practice sample. And it can be a whole policy or even a paragraph or a type of admission. Depends on what you want to share. But we are looking for policies and procedures that you're using that are working for you. More importantly, I want you to stop and take a look at your policy manual specific to swing beds. You can be asked for that manual, and manual I'm using loosely. It certainly can be computer-based, does not have to be in a folder or a binder, but we want to see what kind of policies you're working under. So some of the things that are listed in that manual contents list are items that you don't always have to pay attention to when they're in a hospital bed. There are a couple of policies that are have on that list on elopement because the long-term care setting, which we're under those rules, is a little separate on what we do if somebody disappears from the room or the hallway. So please come prepared to share some of that, and that'll be where we start our day. The policies, I have some questions for you to think about. To be ready to share next week with a group, and we'll do a large group and some breakouts. But I'd be curious as to what was the last policy that you looked at. Was that policy one that you have to check often, or is that one you had to go look for the first time in a long time because of the difference of, and what was that difference that caused that? I would like you also to think about what has changed about your swing bed program in the last 12 months. You know, really, are you doing more medically complex admissions? Are you doing more admissions in general? Are you doing less admissions? Do you have new staff that you're having to train to what the post-acute setting world looks like? And then the last question is, who checks the policies to make sure there are changes? As you know from the webinars, and you know from being in, if you were at the meeting in July, we are in a constantly evolving system right now. There are plenty of changes going on from CMS down to us, and that doesn't even include some of the state things that may be in front of you also. So who looks at those policies, and then who has trained staff that are based on the policies? In other words, you have certain criteria that have to be met by different disciplines. So if you think through any or all of those questions and come ready to discuss those, I think that would be very helpful for us to share that information also. All right, those of you that are PPS, you know you have entered the PDPM world. We are going to continue to discuss this. For those of you that are critical access, it's really important you understand what is going on there because it is the direction Medicare is taking skilled nursing. You are, I think you're about 1,100 critical access hospitals now, but we have 16,000 nursing homes and PPS swing bed programs. So it is driving where CMS wants us to head with this particular level of care. So we're going to be doing some ongoing discussions about this as we go forward. Key thing that you notice is that it is really, it actually should say person-centered care, and it's patient-driven payment model. Everything is wrapped up around person-centered care, patient goals, and then the payment now under PDPM is being driven specifically by the needs of that patient. You get to a PDPM payment category or a HIPS code because you are listing and have documented the nursing they needed, the testing they needed, the other disciplines involved, the therapy they've needed, and even now, very specifically, the speech path involvement with the dietary for things like malnutrition, morbidly obese, mechanically altered diet. So we have a lot of change that will influence the critical access way of looking at the model that they are currently doing for swing beds. But you're not, critical access is not paid under this process. You will continue under your bundled payment. So just to share this real quickly, there are 6 categories in PDPM that lead to payment. I want you to look at the third one down, which is speech, mechanically altered diet, as I said, and they also have malnutrition. They also have the morbidly obese. We always have been able to do swallowing, and we have cognition. So there are a lot of things, as you see out to the far right. There are 12 payment categories for speech alone, and before October 1, there were 0. They were wrapped up with PT, OT, and speech in the RUG payments for therapy as a group. So this is a change in direction for CMS and something that you should look at. The other one that you, I don't have the whole list there, but the next to last one is the non-therapy ancillary. That's a list, significant list, by the way, of comorbidity patients that they expect will be seen in skilled nursing, and they're giving the PPS facilities a chance to get a higher payment for the first 3 days to take on some of those patients. So we'll probably have some ongoing discussions as we evolve and we figure out which of those comorbidities most nursing homes or most PPS swing beds are admitting. I'll be bringing you that information, so that's something you can take into account as you evolve in the types of missions you're doing in the next year also. So what's important from PDPM is important for you if you're critical access. So the first question you have to really answer is, why is this person coming to the facility? They're not coming because they had a hip replacement. That means that's part of the equation. But a hip replacement can go home, they can go to outpatient therapy, they can be in home health. It is the comorbidities and the other needs of this patient. For instance, wound care. Maybe they're a tube feeder. Maybe they need an IV antibiotic, all of which cannot be done in the home setting or an outpatient. So you need to wrap around what you're going to have to document by asking the team, why is this person coming to an inpatient? It's post-acute, but it's a head in the bed. type of setting, because that's what we have to defend in all of our documentation by each of the disciplines. The other thing, if you look at the third bullet down, you'll see PT and OT are being driven by a functional score. We've talked about this and about you perhaps using, if you're critical access, the MDS as a training tool. That would be section GG. I'm asking you again to look at. We want to make sure that our language, particularly for therapy, but also when we look at nursing and we're looking at 24-hour most need of a patient, that we'll be getting to understand what we have to look at and what we're tracking so that we can send somebody home safer. We want to know their function level when they came in, that they made improvement, and they're going to be able to go home safely. I've already gone through the speech. It is something we're going to continue to watch for the next 6 months and see how much of change we see in speech pathology services in swing beds. But I think we're going to see some, and because I believe swing beds are going to take sicker patients, we're probably going to see more speech availability, or the ability to work with dietary in your setting, than even in the nursing homes. I wanted to list a couple things out separately because we're always talking about PPS and critical access and sort of in the same breath, and sometimes that gets confusing. So here's an example of reviewing the process. Remember, PPS is driven by the MDS. I will tell you critical access is driven by documentation and some common sense on what we're getting documented. So if you are critical access, there is a PDPM calculation worksheet. It's 37 pages long. If you're PPS, you have to be using it to get to your HIP score or your payment category for the stay. But if you're critical access, you do not have to complete it. But there's some things on there that you need to understand why we're looking at cognition, why we're looking at mood, why we're looking at what they call the BIM test for mental health. There's a depression, PHQ-9, in the MDS. Those are all tools that the rest of the industry is using. So I think it's important that you start looking through that calculation and see what they're getting paid on. Those are things you could get surveyed on. And so that's why there's a back and forth in this language. This is also a time for you in critical access to understand the significance of the ICD-10. You do not have the MDS to use as the first level of a survey. Your first level of survey is going to be based on your primary ICD-10 code that you have declared for why that patient is in your program. And I think that's an area that you need to self-study, so we will be discussing some of that more next week also.
Carrie,
when you get into, yes.
This is Becky.
Yep.
You might just kind of review again what references for reading you are referring to. There are some that are on the call that haven't attended your program, so that they make sure where they can get that information.
Okay.
I think some of the abbreviations are a little confusing.
All right. So if I back up, the first thing when I talk about functional score, that's in what they call the MDS, which is the tool that PPS hospitals have used for years under the RUG categories. RUG was the way they were paid. Under this new system, they're paid a little differently. And the MDS is about a 41-page tool of questions that all PPS systems must complete, and that's how they get payment. In that tool is a section of the MDS called functional gain, and it develops a score. It is replacing the use of ADLs, or the activities of daily living that we've used in the industry for 22 years, slowly replacing. They're dually available right now. You find a copy of the MDS out at CMS. On their website, you look at the MDS assessment. It'll pull up one of those wonderful zipped files we get from CMS all the time. When you open that up, I think near the next to last one, but you'll see an assessment labeled SP. S is in Sam, P is in Paul. That one is for the PPS swing beds. If you're critical access, I think that's the MDS you need to download and start looking through and looking at the questions they have to answer on every single admission. Because if they're having to do it and 16,000 nursing homes are having to do it, ultimately we're probably going to end up in some form of a tool for the critical access swing beds. So that would be under the MDS, and that's where in section GG you would find the functional score. When I'm talking about the CMS PDPM calculation worksheet, you will find that also on the CMS website under the PDPM tools. And if you can't find it, if you'll let Becky know, and I'll bring a copy with me. In fact, I'll make a note now to bring a copy of the worksheet. But it goes through a series of questions you are asked to make sure that you are getting to the correct payment score for the PPS setting. Well, if those are the things that they're taking towards payment, those are the things we need to know. If we're already documenting it, are we using the CMS language? So I will bring an example of that tool also, Becky. All right. Yep, sure. When we get into certain things, there really is no difference, which is why I have put this up here. So we can talk about speech and dietary working together in some new areas now. The only difference is that there is payment associated with the PPS side, but there's survey associated with both PPS and critical access. So when you look at this list here, it's verbatim. What's important for you to understand about speech and dietary together is working through these issues in your interdisciplinary team meetings. It is a review of your policies and your admissions criteria. For example, let me use a concrete example here. The numbers in the U.S. are that 1 out of every 2 adults over 65 in the U.S. are malnourished. But I would bet you probably do not see 50% of your admissions with a malnutrition diagnosis. I could be wrong, but that's something for you to look at, because if 1 out of every 2 in the country are, why aren't we seeing more malnutrition? That often means when we look at these things and CMS is keen in on them, we're underdiagnosing or we have not caught that in an individual. And remember that malnutrition is not only lack of food, it is also eating too much food with no nutritional value, which is where we see morbid obesity come into this discussion. What Medicare is trying to do with these changes involving speech is saying, look, we're seeing a lot of people impacted by malnutrition and morbid obesity. They're coming back into the healthcare system over and over and over. And if we've got a couple weeks here, 7 days, 10 days, 14 days, 19 days, however long they stay in your swing bed program, to help them work through these and try and set up things for them to stay out of the healthcare system, that's why we're paying for a swing bed stay. That's why you have to look at your policy and your admissions criteria and make sure that you are addressing things that CMS is now drawing attention to. The next part you'll see on there, it's important that everybody has a care plan that deals with these issues. So we'll talk about some of that next week also. All right, as an example of documentation, and I'm not going to do too much of this today because we've got next week where we'll do it in more detail. But if you download the MDS that I asked you to download and look at, you'll see a section K in there that's on nutrition. And what we find is an example, and why I've pointed this out. We obviously have a physician documenting on any nutrition issues. We have a nursing assessment from the time they come in the door that covers any special diets and other nutritional needs. We have speech potentially now involved in this, and we certainly have dietary during assessment. So at this point, we have 4 different disciplines or training identifying a difficulty with eating, whether it's swallowing, all the way to the type of diets they have. But we're not really tying all 4 of those together. So who's stopping in your facility and looking at a medical record and saying, here are these 4 different approaches to the person and their difficulties. Are we putting them on a special diet? Are we adding fortified liquids for them? What are we doing to help this person? So somewhere along the line, we've got to stop and make sure we know why they're on a mechanically altered diet, for instance. When was it ordered? Is it still needed? What's the involvement of all these disciplines in that? So we're going to use this kind of approach next week to look through certain issues. And I'm going to say right here, if you have certain types of things where you have multiple disciplines involved, in your IDT meetings that you'd like to go over next week or use as a case study, please send that to Becky and we'll develop one that fits that. So another one that I bring up is the shortness of breath lying flat, because that is a standard on the MDS for identifying breathing difficulties. I use it because we almost never see documentation says the person can't breathe lying flat, because typically they won't lie flat. They'll have the head of the bed up or pillows behind them. But as you can see, there's a similarity on what we have to document and track for somebody that has shortness of breath issues. The difference is the last line, where the MDS runs the PPS world, but in critical access, it is the documentation of these areas that you will be judged on by a surveyor and auditor. So again, the documentation is the bottom line. And if it isn't written, it's the old thing. If it isn't written, it didn't happen. So as we get more specific into some of these diagnoses, we need to make sure there's documentation to back it up. And that's part of the self-audit process we'll go through. This is another section of the MDS. I want you to look at it if you're critical access for two reasons. One, you see that Medicare has identified 13 primary medical condition categories, and they want the PPS world to pick one of them as the primary reason. The reason I say that is those 13 categories you may or may not admit to your program, but they should be tied into your admissions criteria. It's the first time that CMS has listed what types of patients they expect you to take in this arena. So this is a good chance for you to double check your criteria against this primary medical condition category. The second one circled there is just what I call 20B. All you need to know is that is the primary ICD-10 code for the admission. So I'll say that again. That's the primary ICD-10 code for the admission. That means you in critical access must also identify that at admission. What is the primary ICD-10 code that's going to drive all the services and all the care that's going to be provided while they're in your swing bed program? I'm not sure we're doing that very clearly in our critical access swing beds, so we've got to get better at it. On top of it, remember ICD-10 codes can only be declared by a physician. Your coders will tell you can't even lead them to the water. They can query them, but we need to be educating our physicians on the types of admissions you're accepting. We need to be looking at the types of ICD-10 codes. And one of the reports you might want to run and bring with you are your admissions by ICD-10 in the last 12 months. You'll see a pattern probably developing of 5 kind of common ones, and then maybe 10 or 12 behind that are routinely admitted. That information needs to be shared with your doctors so they get very astute at giving you a complete ICD-10. So, for instance, we do not want an ICD-10 unless there's no other choice with 0.9, which is unspecified. But we do want one that has 0.1, 2, 4, maybe even an A behind it. Whatever is the most specific code for the type of patient you're admitting, we need to have that, and we're going to have to be doing some education with physicians. So right now, you need to look at your primary ICD-10 codes for admission, and we can discuss that next week also. This is a copy of the section GG that I'm suggesting all of you look at to document in nursing and in therapy, at least tie them together. These are just the codes for it. This is not all the questions. There are 5 to 7 pages of questions that are tied to it. So it's an important section for you to begin to look at. All right. Now I'm going to make some suggestions. I'm going to start it off with a warning, like Becky said. We want PHI protected. I don't want to get in trouble with HIPAA. You don't want to get in trouble with HIPAA. But when I ask a self-audit, I usually ask for 2 complete charts, and we go through them from the beginning of admission all the way through the claim. So it would help you if you can bring it electronic. If you bring it paper, that's great. Just make sure the patient information is clearly off the top of it, covered, whatever you need to do to be safe. But it would help if you could look at 24-hour nursing notes, 24-hour therapy notes, whichever disciplines might have been involved with that patient. that you might have a copy of the running diagnosis list for whatever patient you picked for the 24 hours. And then there are certain things that we always have to have. So physician cert, your practical matter statement, which should be in your social services or case management progress notes, a physician progress note during the stay if there was one. It's important now that we start looking at discharge disposition. By that, where did you send them? Did you send them home independently, to home health, to outpatient, to another facility? And then at least for this patient that you're looking at the 24 hours, do you have IDT notes available for that stay? If you have access to this information, I think as we go to help you set up a self-audit, it will make more sense if you can look at the things that I typically will go in and look at. I think it's great that we have Stephanie coming. She can probably give you more concrete information on some of this too, because she has been through an audit process. And so if you have this, it'll help us. If you can't bring it for all sorts of really good compliance issues, I'll understand. But this might be a list that you pull and look at in your facility before you come, because those are the kinds of things that we will be discussing. So, Becky, I think that kind of heads up what we're going to try and accomplish in a very few short hours next week, and see if we can take the next step.
Okay, great. When I send the follow-up information and the presentation for next week's program, I will also include the link to the MDS manual for everyone. And we really look forward to seeing you there at the program. If you have questions that come up in between time, or you think of something specifically that you would like Carrie to address, email that to Shelby and I, and we will make sure that it gets incorporated into the day's program. The Indiana Hospital Association is going to be providing lunch, so we thank the association leadership for supporting the program. And again, we thank the State Office of Rural Health for providing the funding for Carrie to come and work with us on this important topic and helping you build your swing bed program. So I think then that's everything for today. I'll also, when I send out information, we'll also send the list of items that you need to bring, the questions that Carrie asked you to think about, and the list of things that you will want access to. So I think that covers everything for today. Shelby?
Becky, we have a question in the chat box too that was asked a little while earlier. So Carrie, if you're still on the phone here, so Lisa asked, since Indiana is no longer doing the annual state surveys, can swing bed programs be surveyed separate from the hospital, and/or what might prompt a state survey for swing beds?
Yes, the survey can come from three sources: a state survey, a CMS survey, which are CMS surveyors that often come in to see what the state has done or not done, and from your MAC. Your MAC is your fiscal intermediary. So they can come in and survey. They tend to survey more towards the money end. Any state representative or federal representative are looking more at the clinical side. We are seeing more surveys in multiple states. I don't know what's going on in Indiana. That's something we can talk about next week to see if anybody has been surveyed. But they're going to be looking, in your situation with critical access, mostly at, are you in compliance with the conditions of participation? And as you know, part of the conditions of participation are the care and the documentation supporting that care. In other words, having a comprehensive care plan, doing your interdisciplinary team meeting, and those sorts of things. So what we're talking about, you could be surveyed on, does not mean you will be surveyed on. But you need to stay in safe mode as much as possible.
Thank you, Shelby. That didn't come through on my chat box. I'm glad you saw that. I did see the item about what about the question about the annual survey and swing bed survey. So thank you for that. Any other questions? You can also unmute your line if you have a question to ask. Okay. Well, thank you for joining today. We'll see everyone next week. We do have a few spaces available, and so we'll do it on a first-come, first-served basis, but please email Shelby if you have additional individuals that you would like to send that are not already registered for the program. We have great attendance, and again, thank you to the State Office of Rural Health and Shelby and Karen for all of their support. Have a wonderful day, everyone. Bye-bye.